Beginning our second session of presentations, Dr. Louisa Marion-Bellemare is a family physician working in addictions care, emergency medicine, provincial corrections, and Indigenous health care. She will discuss the life-threatening medical condition of opioid addiction and the evidence-based treatments that can help save lives in an emergency. Welcome.
Good evening, everybody. I'm actually a nervous wreck. This is not like me. Anyways, thank you so much for having me, and I just wanted to thank Mike Franklin, who still remains a mentor of mine and influences almost everything I do every day when it comes to addiction medicine. So I loved his talk, and I'm very happy he was here tonight. So I wanted to start off by playing a little video clip of an actual patient of mine and then my own hospital, and sort of give you some ideas of what's going on in my hospital.
Last night, around 4:30 last night, my friend, he was just standing there, and then he got wobbly, and then he fell down, and then blood came out of his nose. He stopped breathing.
I guess it's stopping there. Anyways, I just wanted to set the scene for this evening. Sicily, picture it, 1992. I'm just totally kidding. Anyways, I want to set the scene this evening. And I wanted you to imagine working in a very busy emergency room. And the three following people will present to the emergency room with treatable, you made the text bigger, sorry. With treatable, life-threatening conditions. The first one is a 17-year-old female who doesn't put her seatbelt on, is driving around in a car with her friends. The car rolls over and she presents to your emerge with life-threatening illness, with life-threatening conditions, and she's barely alive. The second one is a 50-year-old male. He doesn't exercise, he's overweight, he smokes, eats fast food, let's say 5 days a week, and he comes in with chest pain, and he's found to be having a very serious heart attack, and he's also barely alive. The third is a 30-year-old female who uses drugs. She started with marijuana when she was at the age of 16 and has never overdosed in the past. But tonight she uses drugs that she thinks is the same drugs that she has always used in the past. And suddenly she stops breathing and essentially dies. She's brought back to life by a life-saving medication called Narcan, and she presents to the emergency room essentially after dying. I want you all to think about these questions internally, and I want you to answer them in your own heads right now. Of those three people I presented to you, who do you think has the biggest risk of death? Who is most likely to receive evidence-based treatment? And who do you think is going to be seen first in the emergency department? Those three questions is an introduction to my discussion around stigma, and Dr. Sullivan talked a little bit about this today, and the treatment of those with addictions in our emergency departments. If we go through the three medical situations and the three different people that I just discussed above, we can probably assume that the person with addictions will be mostly stigmatized, but let's ask ourselves why. Let's dig deep into our consciousness right now and let's figure out why. Do we think it's because addiction is a problem with willpower, which we often hear? Well, I would say the 17-year-old or the 50-year-old probably had a problem with willpower too. Do you think it's a personal choice? Well, the 17-year-old who didn't wear a seatbelt or the 50-year-old didn't care about himself, that's also a personal choice. Or do you think it's just dumb decision-making? Well, when you think about it, the 17-year-old may have made a dumb decision not wearing a seatbelt, and the 50-year-old who's now had a life-threatening heart attack probably made some silly choices too. But what we have to remember is that all of these situations are all life-threatening illnesses and should be treated equally. Addiction actually is none of the above. It's not a willpower problem. It's not dumb decision-making. So why do we stigmatize those with addictions? It's sometimes very difficult for us to understand this. Many of us do this, even those in the medical field that are supposed to be in the job of caring for people and doing no harm. But we set these people up for failure the minute they walk into our emergency room. We stigmatize them, we increase their risk of death because we treat them differently, and we do not provide them with life-saving medication for their life-threatening medical emergency. The person with addiction, if you take those three situations, probably has the greatest risk of death and is probably treated the poorest. So I really like sound clips, and usually I have a partner named Julie Sampson who presents with me everywhere I go, but she's not here to sing with me tonight. So I have to just play the music. I'm uncomfortable singing alone. So I'm going to play you the next song, which I chose because it discusses stigma. Should work. Great song. Love this song. And then we tell you this history.
Never mentions the word addiction in certain company.
So the interesting thing about that song is when the Black Crowes wrote that song, it's not really about anybody at all. They just decided to write that song. I thought there was something really exciting about the song, but when I really looked at the history, there's nothing. But I thought it was perfect to talk about stigma. So let's talk about the problem. Let's talk about the science behind addiction so we can stop stigmatizing people. And there are many factors that lead to addiction, not just one factor. And let me tell you, willpower has nothing to do with it. Typically, medical emergencies prompt us to change our lifestyle. But like these three people's situations that I discussed above, the 17-year-old, even though she was in that car accident, may never wear her seatbelt again. The 50-year-old who never took care of himself that had the heart attack may still eat fast food, continue to smoke, and never exercise. And the 30-year-old who presented to the emerge with overdose may still want to use drugs. But knowing this does not give us the right to not treat these medical conditions because we think they might not change their lifestyle. That's not up to us to decide. However, the science behind addiction will help us understand how there's effective treatment that works almost immediately and at our fingertips to help people stop using drugs. We don't even have some of these medications in other areas of our healthcare system to treat medical conditions. And this medication can prevent people from dying almost immediately. How does addiction happen? If we look at the pyramid of addiction that I have here, plus other factors, we can understand how this happens. And it actually makes us realize how not more of us in this room tonight have ever suffered from an addiction. As people climb through the pyramid of addiction, they go from having increased tolerance to a drug, to dependency, to addiction. And as they climb, their risk of death increases. But once they reach the top of that pyramid, they are addicted. Someone alluded to this earlier this evening about adverse childhood experiences. That is part of this pyramid. Physiologically, there are also things going on in people's brains who have addictions. There's things going on that they cannot control. What ends up happening is they end up needing the drug to feel normal. If they don't use that drug, they feel what's called dope sick. And Dr. Franklin talked a little bit about this evening. So what is dope sickness? What does this mean? It's another term for opiate withdrawal. And I'm going to tell you, my patients tell me, it is the worst feeling ever. It's associated with feelings that none of us could even imagine. You'd rather die than want to feel like this. There's sweating, anxiety, irritability, nausea, vomiting, myalgias, restlessness. The list goes on and on about how these people feel. They can no longer function without the drug. And then they need more and more of the drug to just feel normal, to continue their normal, necessary functions of life. And my patients will say to me, you know, doc, when I could quit, I didn't want to. But now that I want to quit, I can't. I need someone else's help to help me. So let me explain the addiction a little bit further. So imagine, pretend the light bulb is a receptor in your brain. In your brain, we have tons. There's many varieties of the receptors. And we look at opiate addiction as the most common receptor that is affected with opiate addiction is the one called the mu receptor. Most receptors in people's brain are not fully on all the time. When you use drugs, it's like a dimmer switch. It gets turned off, and when the drug wears off, it gets turned on. When people get excited over anything, out of the best food they eat, out of running a race, these receptors get turned on, then they go off. But the first time people use fentanyl, they get that feeling, and it's a reward. It's a positive reinforcement, and that reward system drives them. Just like the first time you eat your favorite food, you think about going back and eating that food again. Imagine using fentanyl and the light bulb is turned on full force all the time. And when a light bulb's on full force all the time, eventually that light bulb, if it's left on too bright too long, it burns out. And in order to feel normal, they use the drug and the light bulb doesn't turn on anymore. They don't get high. They don't get euphoric. They're using the drug just to function and feel normal. But now, in these days, the drugs are contaminated. People can't find the drugs that they would normally use where they could just take to feel normal. They don't know what's in them, and every time they use a drug, they're risking their life and kissing death. This is not intentional. People who use drugs do not intend to overdose and die. This is not a problem of willpower. This is their brain making them do this, where they would die to feel normal, but they don't want to die. So this is just another song by Weezer, which I think is very applicable to this point in my presentation. So here are some interesting statistics. Of the people presenting to the emergency department with chest pain, 0.12% will die 7 days after leaving the emerge. Of those presenting to the emergency department after a non-fatal overdose, 4.4% will die within 2 days of leaving the emerge. This is a 40 times more chance that someone will die leaving the emerge after a non-fatal overdose than those presenting with chest pain. So we have to remember that addiction is an emergency. So let's talk about the science behind the treatment. What is the solution we have to help people who present to our emergency department with addiction? We have a medication that was discussed earlier called Suboxone, or buprenorphine naloxone is the long term and very difficult to say. So I'm just going to use Suboxone. It is a life-saving medication that should be used in an emergency medical treatment in our emergency rooms. When taking it, it only turns that light bulb on partially. And that's what's so important. It only stimulates the opiate receptor partially. And there's lots of benefits to that light bulb only partially being turned on. It does three main things when it comes to addiction. Number one, it reduces cravings, and it can stop people from using drugs, and it can cut their drug use down, and it doesn't allow people to feel high or feel euphoric. It protects people from death. Even giving a person one dose of Suboxone in our emergency department can prevent an overdose death for up to 24 hours. It also treats people's symptoms and treating their withdrawals and engages them in life-saving treatment. We have an evidence-based life-saving medication that has immediate positive effects for our patients at our fingertips. And we aren't using it in our busy emergency rooms. It sounds kind of crazy, doesn't it? So why don't we start using the best medicine to treat people in our emergency with addiction? Suboxone binds to that receptor in your brain like crazy glue. When it binds like crazy glue, if someone walks out of the emergency department and decides to use drugs, the fentanyl cannot bind to that part of the brain, and they cannot overdose, and they cannot die at that time. If patients decide to stay in your emerge and continue to get help, well then they're feeling better, their cravings and their withdrawals are controlled. But if they do decide to leave, you have protected them from the risk of dying, and you have literally given them a taste of the positive effects of a life-saving medication. We should be using medication to treat addiction like you do any other medical condition that comes into your emergency department. Listen to this story. The person who has a heart attack. You don't say to them, "You're going to recover from your heart attack cold turkey. Let's see if you can do it. You probably will fail. You probably won't make it. But you know what? You might have another heart attack and die. But I want to see how many times you fail cold turkey before I decide to give you the life-saving medication you need." We don't make people who have heart attacks earn their treatment. You give them the treatment because it's the right thing to do. For example, the person with the heart attack may have a genetic predisposition, just like the person who has addiction. but the right thing to do is to treat them with life-saving treatment. We have to treat people right away. For those presenting to our emerge and withdrawals or fully reversed from Narcan, they should immediately be treated in the emerge to stop them from dying. There's a position statement set out by the Canadian Association of Emergency Physicians in 2019 to support the use of Suboxone in our emergency departments, but very few emerges have adopted these guidelines for reasons I cannot explain. Is it culture? Is it stigma? I don't know what it is, but I know it's a life-saving treatment. Clinical practice guidelines similarly exist for the treatment of cardiac arrest for a heart attack, and they are almost immediately adopted when they come out in our emergency department. We need to change culture. We need to change existing clinical practices, and we need to start reducing stigma. Even if, as practitioners or people in the community, even if we cannot put our biases aside, we cannot deny people life-saving treatment. We need to advocate with our patients with addictions. We know addictions has an associated high risk of death. And if we denied someone having a heart attack treatment in the emerge, people would think we were crazy. The patient with a heart attack will be provided with follow-up appointments, seeing specialists for months to years. So should our patients with addictions. I'm going to play this song because what I presented to you all today was the problem and a solution. We always hear problems, but the important thing is we need to have solutions.
People asking questions, lost in confusion. Well, I tell them there's no problem, only solutions.
So we have to remember that. When we're presented with a problem, we need to find a solution, especially for life-threatening conditions. So a few things I want to end with. These are my patients. Every single one of these patients I met in my emergency department, and I have some medical students here today that worked with me in the emerge in Timmins, and they've met these patients. Every single one of these patients were started on Suboxone in my emerge. And 8 months later, they are still not using drugs, and they are still on their life-saving medication. One of my friends, a very close friend of mine, Seamus Murphy, who's a paramedic in Timmins, says this all the time. A life saved today could be a life change for tomorrow. We are in the job of caring and treating people. We are in the job of saving lives. We don't get to choose whose life we're going to save in the emergency department. We are in the job of saving all lives that present to the emergency setting. All of us here today can be part of saving lives and be part of the solution. We need to advocate for people with addictions, start reducing stigma, encourage change at all levels, including political, community, and healthcare. Let's allow people to get the life-saving treatment they need and deserve in our emergency rooms. And of course, this song is next, Start Me Up on Suboxone. Thank you very much.